things been working. EPI is one of the departments within the primary health care, and EPI is working with groups. One of the main pillars in EPI, we have something called EPI Technical Working Group. This is where the EPI discussing their technical things and then take the decisions to be sent to the states and the counties. And we have the ICC. The ICC is an inter-coordination committee being chaired by a minister. We have a main donors, the pillars of those committee. ICC is the one approving everything in EPI. Once we did a plan before being submitted to the donors, we'll present to ICC, and ICC will endorse it, and then we'll submit. And we have SITAC, South Sudan's Immunization Technical Advisory Group. We are not just doing things from our head. If we want any new vaccines, we'll raise this case to them, will be discussed to agree that yes, these vaccines will come to the country, and they will give us the advice. And that been shared by Dr. Robert Napoleon, and Robert Napoleon being deputized by Betty Iobo is a deputy of SITAC. And also we have NCC, as was been mentioned by Dr. Rose, the National Polio Certifications Committee. The National Polio Certifications Committee, they are one of the pillars of the monitoring the EPI activities. Every quarter we're presenting to them to tell them how far we are, because the polio have the three strategies. One of the main strategies for polio eradications is a strong routine immunizations. So without the strong routine immunizations, we're not able to do anything. That's why these committees are helping us. And we have also National Polio Experts Committee being chaired by Dr. Justin. Is the one responsible for reviewing all the cases to classify it in the way that to see the case, is it polio or not polio, so they're responsible for that one. Also, we have one of the committee, the one been doing for us, if we have the cases, the one responsible is a lab being shared by Gorigori, Wani. So these are the committees supporting EPI to do the right things. So on this juncture, I just want to say, we started the journey of the PCV and Rota officially since 2021. The 2021 South Sudan's EPI department was being invited by the every last breath to present. So we present our case at that time to make a lobby, as was being mentioned by Professor Rose. This is supposed to happen since, but because of the issue of some challenges, this is why we are not able to go. So since that time, the every last breeze, they take action. 2023, we have been invited in chat to put our case officially as a country, me, DG, Under Secretary, UNICEF, WHO, but fortunately, because of the many activities, DG and Under Secretary, they are not able to go because they have been also grabbed with some activities. So they authorized me to move ahead with activities. So we raised our case there, and the case was being accepted. Since there we have been, it started 2024, the first quarter. We've been given the green line by Gavi. They hired for us a consultant. We wrote the applications. Wrote the applications, everything, and then we raised our case to CITA. We get the approval. We submit our applications. Exactly in July, we got the notification from Gavi that your case was being approved with some amendment. So normally for Gavi, after that they will send all the document to you, and then you will go through it, sit as a country team to respond to those amendments, the questions. We went through until September exactly. We got the final approval. After we got the final approval from Gavi, we started the preparations. One of the things that we start updating our IIP documents. IIP is immunizations in practice documents, to include PCV and Rota in. So because that document is where we can use it as a training tools to be cascaded down. So that things was done. We move, and we now the higher or the advanced level. We finished TOT. We call all the EPI managers and the officers, 5 from each state. We call them in Juba. That one is last month. We brought them here on 10 exactly of March. 10 of March, we conduct the TOT training. So now telling us that we started the process. What is remain? The training of the counties staff and move to the health facilities. Our readiness assessment for the campaigns, up to now, we have 78% ready for introductions of the PCV and Rota. This one is under the national level. On the state level, each state having their percentage. But normally, based on the readiness assessment tool, if the state of the county reach 80%, means they are ready, because the 20% is where the implementation is. So up to now, we are 78% national level, and we remain with some things. Disbursement of the vaccines from national level to the states, training funding to the states. This is what is remain. This is the main things. This is where we are now working, because we are in the measles follow-up campaign. Immediately after measles follow-up campaigns, we'll go direct. So the date for measles, PCV and Rota introductions was being fixed. 27 May, sorry. The launching is supposed to be in April, but due to some things and the readiness, this is why we push to May 27. The official letter was being sent to all the states, communicated by Under Secretary to them. I think this is our situation and the status of PCV and Rota introductions. What I want to say, like been mentioned here, the South Sudan ready for introductions. These are the vaccines that we have been waiting it for a long time to save lives of our children. The challenges, one of the bigger challenge for us is this issue of the co-financing. The co-financing is one of the bigger challenge, but we thank God on 10 or 12 of February, we have been in this room with the parliamentarians and Minister of Finance, Health Committee and Finance Committee. We raised this case of co-financing. So I think all the members, they are ready to support Minister of Health, especially the EPI, because the primary health care is one of the basic things, even from their response and the way they accepted the ideas. So means that the coming financial year, the co-financing for vaccines and traditional vaccines is one of the things going to be the key element for the coming financial year. From the agenda, they're talking about the opportunities. Yeah, one of the opportunity, we have a system. All the system is there. The EPI from national level to state to the county. We are not going to put something parallel. We're just going to go in and using the system what we have. Cold chain, we have a cold chain, the same cold chain we are going to use. We are not going to bring new cold chain. The only things, yes, once you now introducing many vaccines, means the storage capacity will be small, because this is what you have before for 10 vaccines, and now you are bringing 15 vaccines, means you need to expand the cold chain's storage capacity. These the challenges, but it's not going to stop us to move ahead. We have an official letter being communicated by Gavi, they call decision letter from Gavi to Minister. We are ready for PCV and Rota. Therefore, I don't have much to say. It's good now the share of pediatricians is here, and many pediatricians in the rooms. This is the appeal. I need you to work. These things called missed opportunity. The missed opportunity normally happening when the clinicians is not putting the immunizations as a priority. So I'm just requesting you to work with us so that we'll have a good coverage, not like the one of malaria, as a DG mentioned, because when we have a good coverage, means we are really protecting our children from this dangerous or the killer disease. I think about the immunizations general, our coverage of last year, Penta 3, we have 91%. And this 91% globally is accepted coverage, because 80 above is accepted. But I just want to mention here, it's not means that South Sudan is now 91%, we're able to finish all the children. I will say no. Why? Because all of you know that since 2022, the fighting, 2023, fighting started in Sudan. We received the refugees, returnees. Our denominator was fixed. Numerator is going up. So means there is something here. We have been vaccinating. the numbers that was not being considered in denominator. So now this is why our coverage is 91%. Penta 1, where there's the initial immunization, we have 102, means we vaccinate more than our target. The reasons is because of the influence of refugee and returnees. So it's not means that we finish all the children, but we're still having the children. Why? If we went to the details by counties, yes, we have the list of the counties that have higher zero dose. This is why we now started this month something called the big catch-up. The big catch-up been conducted under the 30 counties with higher zero dose. Although we have 100 above, but we're still having the zero dose when we went to the details. Let me give you an example, Juba County. If you went to the record, register book, tally sheets, monthly report, the Juba County having 120%. This is a Juba County. Why? Because it's a city. There is many children being brought in after the census of 2008 have gone. So, if we went to the details of Juba County, we start going by Payam. You will see this 100 above is under the 5 Payams. The 3 of Juba, Kator, Munuki, Northern Bare, and Rajaf. But the rest, some of them is less than 50%. Because the Rasham children run even to the Juba. If we went to there. So means that we still have a work together. We can reach the children, the hard to reach and unreach, as one of the logo of the immunizations. They say no one being left behind. I think this is what I want to say. Thank you. If there is any questions, you are welcome.
Thank you, Mr. George, for that informative narrative on the PCV and Rota journey, and generally on immunization coverage in South Sudan. Now we're going to have a presentation on the country readiness and updated timelines by UNICEF.
All right, thank you, and good morning once again. My name's Douglas Mukwaya from UNICEF, and I just want to give you the timelines and on how the introduction is going, all taking place. First of all, dear DG, the Dr. Tem, George, the Director SWIM, protocol observed. I would like first of all to thank SWIM for this good initiative, because once all health workers are on board, then we know that the introduction will go on well. As Dr. Tem mentioned before, that some of these mistakes shouldn't be repeated. We've learned from the malaria introduction, whereby most of us were not brought up on board, and probably we had some challenges in terms of during the introduction of malaria vaccines. I would just want to reiterate UNICEF's role, especially the role UNICEF plays in supporting the government as well as WHO. As UNICEF, we're responsible for logistics, vaccine and logistics management, supporting government, and communication, that is the SBC part, the social behavior change. While WHO is responsible for the policy guidelines, the trainings, and the surveillance. So we divided some of those roles for us to be able to support government well. The other issue at hand is the information that health workers are having. we suppose that with new introduction of vaccines, there are so many questions that rotate around the introduction of vaccines. Why this vaccine? Why at this time? Why for this age bracket? But with such sittings, I hope that information will flow well to all health workers, because down there at the facility level, you are the people that mothers, all fathers, all caregivers will be asking questions. And if you are not ready to answer some of these questions, it will bring a lot of back and forth between the caregivers and the health workers. So once again, I would like to thank SWIM for this good organization, and probably such meetings should be repeated every now and then. I know in terms of where we are, Dr. Tem touched a bit of it, George also touched a bit of it, but also what I would want to mention that during all these preparations, you know, with new vaccines, there are so many things that are in the background that need really support. And I would like to thank also WHO for the consultant that was brought on board to support the PCV and Rota introduction. Unfortunately, I'm not seeing the consultant in the room. Maybe WHO will help us to that, but I would like to thank WHO for that. In terms of the readiness, we've got a readiness tool that we are following as a country. This readiness tool operates from the national to the states until the counties. Just like George mentioned, that the moment the county or any level reaches 80%, we presume that it's ready to start off the campaign. And as we speak now, at the national level, we are at 78%, and we're also trying to monitor the different states to ensure that they come up to speed to see where we stand. So in this readiness tool, there are some key pillars that were taken care of. For example, the development of the guidelines. Again, George hit about this. We have to review all the previous guidelines. Remember, these are new vaccines. It means they have to go into the new guidelines. They have to go into all the documentation. All the documentations and guidelines have been updated, as well as the data tools, because when introducing new vaccine also, you have to update the data tools to ensure that all information is well captured and fed into the relevant tools. Training at the national level has been completed, and now we are looking at the cascaded trainings for the state and counties. And these trainings will happen after the measles campaign. Once the measles campaign is done, now we shall embark on training of the health workers at the county and the state levels. In terms of supplies, of course, you can't introduce vaccines without the supplies. I'm glad to announce that the vaccines are already in country. We received 2.7 million doses of PCV and 300,000 for rotavirus. Of course, more vaccines will be coming, but due to space adequacy at the national level, we couldn't receive all the vaccines at once. So we agreed that we shall be receiving it in batches. Once this one goes to the field, then we shall request supply division to send us more vaccines. The PCV vaccines is packaged in the 4-dose vial, meaning that one vial will have 4 doses. While for the Rota vaccine, it is 2 doses. One vial has 2 doses. One of the issues that has been rotating around all countries globally is the vaccine wastage. Most of you know vaccine like BCG, which is packed in a 20-dose vial, wastage is up to almost 80%. And when we talk about wastage, it is money being thrown away. That's why for countries to introduce new vaccines, there are different parameters that Gavi necessitates you to have in terms of vaccine wastage. How is the EVM report scores? How are you doing in terms of vaccine management practices? But I would want to thank Gavi that some of these things were waved off from South Sudan, and because South Sudan was lagging behind in terms of introduction of new vaccine, so Gavi approved the application, and they have been able to give us the funding for vaccine introduction, but as well as the vaccines. Gavi supports us in procurement of new vaccines like IPV, Penta, now it's going to go into PCV, Rota, while the traditional vaccines like measles, BCG, polio, and TD are supposed to be procured by the government. But UNICEF has been playing this role, but of course, like all the previous speakers have said, there are talks going on to see how also government can come in to start funding the traditional vaccines. In terms of surveillance, the AFI tools and guidelines have been updated and I think already approved, and they will be shared. For advocacy, the advocacy plan has been reviewed. The key messages and materials have been developed. But of course, as I mentioned before, when you introduce new vaccines, there is a lot of questions. Why? Why these vaccines now? Why this age bracket? And what are the repercussions? So with that, the SBC team has managed to work on the crisis communication. Those are the issues that come up during the introduction. And we expect that as health workers, you'll play also a key role in having these messages and being able to attend to all caregivers in the field locations that come to you, because at the end of the day, you'll be the people at the front line and all the tough questions will be coming to you. Lastly, in regards to the financing, I'm glad to say that also Gavi provided us with the vaccine introduction grant. This is a grant that comes with some small money to cater for some activities that go with the introduction of new vaccines. And just like mentioned, that from the lessons learned during the malaria introduction, we thought that that's what even caused some of the high dropout, because of the funding was not quite adequate. And all these key lessons have been put on paper and have been well articulated in the planning, in this new planning for Rota and PCV introduction. Like George mentioned, the introduction will take place on the 27th of May. It was delayed because of we wanted to put the measles campaign out, then we can embark on proper planning and proper planning for all activities for the introduction of the new vaccine. Currently, like mentioned, we are at 78%, but hopefully with the coming few days, all weeks, we should be able to reach a good percentage for us to be able to introduce the new vaccines. And with that, I would say thank you, and feel free please to come in with any question, whether during break time or lunch time, in case you want to understand more on the Rota and PCV introduction. But again, I would encourage all health workers to be able to go to the UNICEF and WHO websites and try to ensure that we have all this information on fingertips to be able to respond to the communities whenever they get us. Thank you.
That was the cold chain and logistics specialist, Mr. Douglas Mukaya from UNICEF. So if you have any questions about cold chain, please feel free to ask him later on. Now we're going to break up for the first panel discussion. And it's almost 12, so perhaps we'll carry forward the discussion until lunchtime, and then we'll break. So while we're preparing the chairs for the panelists, there's a video they would love us to watch before the discussion. So please, the Secretariat, if you can present it up there. Thank you. Perhaps while they are still arranging the chairs and the Secretariat is still putting up the presentation, if you have any burning question for Mr. George Lege or Mr. Douglas Mukwaya, I think this is an opportunity to ask. Please make it precise. Thank you. Yep.
Thank you. I'm just inquiring the denomination of the children, that is the target population of the children to be vaccinated. What is their percentage from the total number of the children in the whole country? Thank you.
Okay, thank you. Yes, I think for us, in routine, when we're talking routine, we're targeting the children under 1. It's from 0 to 11 months. From 0, we're starting with the BCG and 0-dose polio. Then 6 weeks, we continue with the other vaccines. So the target, our target normally move according to the year. We are targeting the 4% of the children from the whole population. Like now this year, we are targeting the 600,000 children. Yeah, this is just what I can say. This is the children we are targeting because the target, as I mentioned, like now we reach 100%. Yeah. Normally, the number of the children you reach, if you plan before, for 20%, but during the actual work, you reach 50%, means the 50 will become your target for the next year. So now, for this year, we are targeting 90 above this Penta 3, and normally the Penta 1 will be higher. So the PCV and Rota, we are not going to reach the 100%. Why? Because we are now starting from the third quarter. The third quarter we are starting means we are missing all the children who miss, they finish their immunization in first quarter. If we don't have a strong awareness or the mobilizations, means they will not come to the facility. Automatically we will not reach PCV and Rota, will not reach 70%. But our target from during the applications, we need the 80% Penta 3 and 90% Penta 1. Oh, sorry, PCV 1 and Rota. Yeah. Why I'm just saying Penta 3? Because for us in EPI, the Penta is the indicator. That's why we're there. Thank you.
Okay, what I mean was, do you go up to the children in the borders, for example, of South Sudan and Ethiopia, Kenya? I mean, the coverage of children, the total population of under 5 children, that make about 20% of the population.
Yes, we have been named as a countries. Normally, when we are doing any works, we are doing within our territory. Any child cross the country, we are not longer responsible for it. But any child enter the country from Ethiopia, from Uganda, from Kenya, we are responsible. This is why I mentioned from the beginning that our coverage is of Penta 1 is 100 above. Means there is many children came inside, so we are targeting. The children under 5, to reach them, in EPI we have 3 strategies. We have a fix, this is where the health facility is. The mothers will come to the health facility and will vaccinate them. We have outreaches. Outreaches is those populations who are above the 5 kilometers from the health facility, 10 kilometers above. So we'll go to them. We have the outreach, at least each health facility will have 1 session per week, we'll go outside. This week he's here, and then the other week we will go there. At least the areas that we, under the catchment area of that health facility, but it's not near to the health facility, so the team will go there and vaccinate them. We'll go to that place at least a month. So because means if you come here this week you come here, and then the other weeks of other months will go back to finish the series of all the schedules of the immunization. And then the third strategy is we have the mobile. The mobile is the hard to reach children, like you mentioned, those who are far. Like let me give you example, and Kopoita is Nachodokopele. How many people hear about Nachodokopele? Nachodokopele? Yes. The team in EPI, they are the one here, Nachodokopele. Nachodokopele is one of the famous areas being known in the EPI. If I ask here, some people will start saying, 2017, what happened in South Sudan in EPI program? 2017. 2017.
There was a measles problem.
Measles.
Yeah, there was a problem in Koboita at that time where it was perceived that measles vaccination has caused deaths of some children.
Yes. So 2017, because of some program errors, there is a team of the children being nominated to vaccinate children. So they make mistakes, and some people want to save something. You know, al syringe bita 5 ml o muhim fi bara henak. So they start using one syringe for the 5 days and cause the problems, kill 16 children. So that event happened in a place called Nachodokopele. So for Nachodokopele, we have a team. We'll go there for mobile. They will stay 4 to 5 nights to reach those children and then come back. So this is how we are reaching the children. And then there are some things we use called dry season activities. This one is strategies. We use it in Upper Nile, especially the Upper Nile regions, because during the rain season we are missing the children because of the access, the roads. So dry season like this, at least we'll have 3-4 rounds going to the hard to reach, vaccinate the children. When the rains come, we already have a good number of the children, we reach them. Thank you.
All right, thank you, George. Do we have any other question?
For mine, I think it's just clarity. I think I didn't understand this part very well. You were talking about, I think the rate now is 91%, the last one that you had, coverage. So, and you mentioned about in the last, I think, 2 years, we've been able to have people from Sudan come into our borders. And that 91% was attributed basically not the change. I think the denominator, the lower one is denominator, has not changed. So now that we want to introduce this PCV and rotavirus, you're saying you want 90%. That is, I believe, is still the same denominator. Is there any? Are you thinking of maybe now coming to be able to get the actual right denominator, or are we still going to play with that 90% and not changing the denominator? Because I feel that doesn't really give us a good figure. And it almost looks like those who came from Sudan are going to be around for a period of time. So they're actually constant. Thank you.
To change the denominator is a scientific exercise. The right thing to do is you do a new census, like that you come with new figures and then you adopt them. Until now, the figures we are using is the old census, and then we extrapolate every year based on, then we come. The other thing is the entry, if it is organized and they come through routes where you can count them, is okay. But people come through Panya roads, and you don't know, and even they come and go. So you cannot, if you put arbitrary figures, then the whole thing is messed up. So it's only good that to know when you are overshooting your target, you know where that is coming from. Yeah, but change the denominator is not automatic. If you do it by assumption, then the whole game is messed up. Thank you.
Yes, thank you, DG. Just something very small. Just what I want to say. The population that we are using, every year we are receiving official communications from Census, National Bureau of Statistics. These are the populations you are using. So we're not able to change anything until that things happen.
Thank you. Let's keep it precise.
My question is in regards to vaccine wastage. I think I just want to, okay, maybe they just give us more detail on what are the percentage of wastages that the country is currently facing, and what could be the factors that are attributing to that. And for me, I could just give a comment in the area of the factors which became a norm actually, that you find that the procurement is done ahead of planning. So you'll find that the commodities arrive within the country before the other steps are done, like the launching, the introduction, the SBC at the community level, even updating of the tools. So given that we already have those ones on our back of our minds, so what could be the next steps, and if there is any assessments which have been done, you know, to give us really the clear picture of the magnitude of the wastage and how we can mitigate it. Thank you.
I think this one should go to UNICEF.
All right, thanks. So in terms of wastage, different antigens have got different wastages. And in most cases, it depends on the packaging. I gave an example of BCG. BCG is packed in the 20-dose vial. And when we look at the government policy, it says immunize any child that comes. It means if that child came alone at the facility, you have to open the whole 20 vials, immunize one, and you're going to lose 19. That's why at the global level, when it comes to vaccine wastage, we're advocating for reduction in the packaging. The first country that used PCV, it was a 10-dose, but now they have reduced it to 4 doses, such that if you open one, at least you waste 4 instead of instead of wasting so many doses. For Rota, they have even got a 1 dose, but of course, the lower the doses you get, the more the storage capacity that you require. So it is either way. So the causes of vaccine wastage are quite a lot. Of course, this is not closed vial, this is open vial wastage. There's a lot of issues regarding the wastage. Sometimes it's the practice. You find that the VVM has changed, all the vial has got contaminated. So, but in most cases, it is the practice whereby save a child and lose the rest. Thank you.
When we planned last year, we did not know that a cholera outbreak will come. And when the cholera outbreak came, we did not have a space to store the vaccines. And our capacity was stretched beyond the limit. And so now we had to even suspend the importation of other vaccines until we are able to push the cholera vaccine out. And cholera vaccine is a single dose and it's bulky. So it occupied all our space. One of the remedies was we have redundant capacity in Rumbek, because Rumbek used to be the hub for the whole South Sudan before the war, and also in Wau. And so we now have brought them to functionality, and soon we will be pushing some of these vaccines to those sub-regional places to create more room for vaccine storage. But vaccine storage is a big thing because cold chain needs power to maintain it, need personnel to look after the vaccine to make sure. So it is not an easy job. It brings more problems.
This is what we get, so that's why we say the minute we have this kind of doses that are minimized in a vial, increasing the capacity where the fridge should be, like we need more capacity in the fridges. And as we are speaking now, it's still, the health facilities, even the PSCCs have capacities that are lower than what they're supposed to have. So that one is affecting the potency of the vaccine. When we import vaccine like this and we push them to the field, the staff will do whatever they can to store them. But we are losing a lot of potency because of that. And vaccine management is not well established at the county level. We still have issues.
This is not county. This is sub. Those are sub.
If you have this problem as subnational or national, imagine the same problem cascading down to the county.
No, you are not getting me. The vaccine, like the one in Rumbek, it used to be the national hub. So it is not going to be under the county or anything. It is part and it's an extension of the national vaccine store. We will have people from the national looking after the vaccine and who have the capacity to take charge. We are not pushing it to the users. So it is not, yeah.
Also, I'm going back to what Douglas was saying, because once those vaccines are now being pushed to the field or to the counties now after the introduction, and now they're going to start as part of the routine immunization, we should put out in the back of our mind that the capacity at those locations are very limited. So even now as we're speaking with the vaccines that we have and with the cholera outbreak and the cholera vaccination that is going on, plus also the measles campaign that is now going on. After the measles campaign is finished, there's a lot of measles vaccines that are left in the counties that are not used at the level of the CADs or the county vaccine store. I understand, Dr. Atem, what you're saying, and that one is good.
We should agree, we concede that we don't have enough vaccine storage capacity. That's the starting point.
Yes.
And the vaccine storage is donor dependent. And also let me tell you, the last 2 years we had floods and we lost
A lot of, cold
vaccine
chains.
storage to the storage,
Yes.
to the flood. So if you want to solve it, you solve it at the donor level, at the partner level, not at our level. We are managing, we're dealing with a bad situation at our level.
Okay, that's understandable.
I think this discussion is becoming really very juicy, and we all want to talk, but we have to kind of bring it to an end. Can we continue during lunchtime? One word, 2 words.
Yeah, thank you. I just want to make it a bit clear, because there are some words that we use which are quite strong when you say that vaccines have lost potency, and if it comes from a health worker, it's quite challenging, because from just mere looking at a vaccine, you can't see that the vaccine has lost potency. There are some gadgets that are put on the vial, like the VVM, which is a vaccine vial monitor, that helps you to monitor that particular vial, or if vaccine is expired. But vaccines being in the fridge, as long as it is at 2 to 8 and it is filled, you can't say the vaccines have lost potency. That is a very big word if it goes out. It shows that we are giving vaccines which are poor quality or substandard. As long as the VVM is still okay and the temperature of the fridge is between 2 and 8, the vaccines are still safe to use. Thank you.
All right. Thank you. Now to our panel discussion. Let's have the video. Meanwhile, the panelists, please come up. I think we'll continue after lunch or during lunchtime. Yeah, or during the panel discussion, we can continue. This is really an important topic. Thank you very much for participating in the discussion. We've decided to cut the video short because I'm sitting very closely and I'm not even hearing anything. So I wonder if you guys are hearing anything at all. So perhaps we'll listen to it later on when we fix the issue of the microphones in the room. So for now, let's go to the panel discussion. The panelists, please, you're welcome. Thank you.
I will call the panelists one by one. We will be joined by a panelist virtually, one of the pediatricians, but who also happens to be an infectious disease specialist. So yeah, thank you very much, the team that has done this so quickly. So yes, my name is Dr. Koiti Emily, as I introduced myself earlier on. And so it's time, we've lost so much time, but I'm going to try and push this panel. So be forewarned and forearmed those who are coming to speak on the panel that we are going to try and take as much short time as possible so that we break for lunch. People are hungry. That tea wasn't enough for me. I am confessing. So I am pseudo-hypoglycemic there. My sugar is low. So yes, now is the time for us to have our first panel discussion, which is going to be titled the Clinical Perspectives on Preventable Childhood Illnesses. And I have the honor to invite our first panelist, who is none other than Dr. Hassan Cholong. He happens actually to have taught me in medical school, but I am sure he doesn't remember my face. And I knew that I would have to remind him while on this panel. So let's give an applause to Professor Hassan Cholong as he walks to the stage. And our next panelist is Francis Mangui. He's a clinical officer. Is he in the room right now? Oh, yes. You took a bit of time, so I thought maybe you stepped out. Yes. So that is Francis Mangui. He's coming from the Association of Clinical Officers of South Sudan, and he's going to be sharing with us a rural perspective, a perspective on rural child health. The next panelist is none other than Dr. Eric from WHO. Please let's give applause as he comes. Sorry that. And the last one is a very hard-working colleague for the few weeks I have known him from UNICEF, the social behavior change focal point. That is Api. Yes, thank you very much. We are seeking some clarification here. Yes, so I have again the honor of introducing these people. I feel quite small to have to introduce my professor, but because it's a once in a lifetime opportunity, it's once in a blue moon thing, I'm going to introduce him as a panelist on this panel. So Dr. Hassan Cholong is an associate professor of pediatrics and child health at the University of Juba, and he has more than 20 years in practice as a pediatrician with profound experience in child health issues, including infectious diseases. He has been a member of the Immunization Technical Working Group at the Ministry of Health, our Ministry of Health in South Sudan, and formerly also in Sudan before we separated. He was, at that time, a member of the National Polio Eradication Program, in addition to him having been appointed as the Director General for the Ministry of Health in Al-Fasher, in northern Darfur State. He is a member of many doctors' fraternities or forums, and he has supervised many postgraduate students in completing their thesis, especially in pediatrics and child health specialties. He is currently one of the patrons of the South Sudan Pediatric Association. Once again, let's give a clap of hands to him. And then we have Eric. Dr. Eric is the Immunization Hub Coordinator at the World Health Organization country office here in South Sudan. And he is a medical doctor. He is the one seated on my far left, if you didn't see him walking up the stage. He's a medical doctor with strong clinical skills in internal medicine, holds a master's in public health, disease control, postgraduate, there's something, FELTP. He has extensive experience in humanitarian assistance, immunization programming, humanitarian affairs, evaluation, monitoring, program, project management, and many other things. He's worked with different entities, including ministries of health, the World Health Organization itself, collaborates with UNICEF, the World Bank, the International Federation of the Red Cross Crescent, and he also worked with Save the Children. He worked in Rwanda, Sierra Leone, Kenya, Burundi, Bangladesh, Democratic Republic of Congo, Central African Republic, Ethiopia, and currently in South Sudan. He speaks English, French, and Swahili. So he's quite a polyglot. Yeah, and then we have, to my immediate left, Walter Mangui. Walter is a clinical officer, and he is also a medical educationist. He is the founder and initiator of ACOS. He holds a diploma in clinical medicine and a high diploma in health personnel education. Now we also have a pin, and a pin. Let me get. Apin Kluel is the Social Behavior Change Officer on my far right of UNICEF South Sudan. And he's been with UNICEF for the past 11 years. One of the most loyal employees you can come across. And his role has been providing technical support on social behavior change interventions, both for EPI and emergencies, including PH emergencies, and also the co-lead for RCCE Technical Working Group. You're welcome, Apin. And so I have done something that the team is not very aware of. There are people who I brought on this panel deliberately. They were supposed to be on the second panel, but the second panel will still happen. And now I want to confirm whether we can, Dr. Adut, Christine can, Dr. Adut can hear us, Chan Bol can hear us, she's online. If she can speak, if she can say something, so that we confirm if she can hear us, would be great.
Yes, I can hear you. Good afternoon, everyone.
Fantastic, fantastic. So that is the voice we've just heard is one of Dr. Adut. And Dr. Adut is a consultant pediatrician. She is a consultant pediatrician and child specialist. She is a neonatologist but also an infectious disease expert, and she'll be joining this panel in that capacity. While the other pediatricians, more senior pediatrician, is going to be sharing about things that are related to a long-term experience. Of note is that Dr. Adut is a junior colleague to Professor Hassan. So I will start off with Professor Hassan, real quick. Some of these questions were shared in advance because we thought we would be able to save on time. And let's talk about, we've listened to the EPI manager, we've listened to the Director General of Primary Health Care, we've also listened to the presentation by UNICEF, and we see where we are. I also listened in as a clinician myself, as a medical doctor, and realized that there's a lot that we are not aware of, but there is also a huge way in which we can support immunization in our country. And the DG mentioned something very important, that it's important that we are part of this. That has been echoed differently by the previous speakers. So let's talk about pediatric impacts. What are the most common vaccine preventable illnesses you have encountered in your long experience? We've talked about 20 years, over 20 years of experience as a practitioner. And how has vaccination or have vaccination programs changed the landscape of pediatric health, most especially here in South Sudan? Yeah.
Thank you, Dr. Kwete. I would like, to go back to what Dr. Kwete said at the beginning with regards to recognizing them as my students. In fact, it's a long time. We have been away from each other. I was not around. I taught them in 2016, and then I happened to go to Khartoum. I stayed there for a long time, and I've come here, but we couldn't actually have the opportunity of meeting. Dr. Kwete was one of my clever students, and she usually wants to sit in the front row. In the story of vaccination or immunization and its role in the pediatric practice cannot be overemphasized. In fact, immunization is part and parcel of our practice. We usually screen our children when it is particularly relevant, when a mother comes to the office for consultation. The common preventable diseases through immunization, the first 6 diseases, in fact, have been controlled, especially in the urban areas. The effect of vaccination may be still limited in the rural areas, maybe because of so many things. The attempt to cover the rural areas may be there, but there are also the choices of the family, because it's not something that's done compulsory. There are choices for the families to make to bring their children. But I think I'm now very comfortable in that we are not seeing cases like whooping cough, diphtheria. They are in fact going to be historical things. You only get them in the margins of the textbooks of medicine. Tuberculosis is still there, but in the urban area, it has also declined. Most of the cases do come from the rural areas because of other factors that may actually pay for the immunization, infection of the children, especially in the rural area. The life is simple, and the family may not think of isolating any member of the family who has an infectious disease like tuberculosis, so it disseminates. So in assessing such a child who comes with chronic cough, we always ask about the history of contact, whether there is a member in the family who has got a chronic or a prolonged respiratory disease, or on chronic intake of antituberculous medicines. The other diseases, for example, tetanus, tetanus neonatorum, is also limited in the urban area because of the proper coverage of vaccination. But sometimes it comes from rural areas where some of the practices which are related to our cultures, using some materials for controlling and working on the umbilicus, sometimes an ash from the kettle camp can be brought and applied on the umbilicus, which may include, the spora of the Clostridium tetani, or they may use sometimes a sharp material for cutting the umbilicus, which may not be sterile. But the good it's not infectious, it's not contagious. If you have a child, a newborn child with tetanus, it's not going to actually give the disease to the other children maybe at home. So it is not contagious. That's why it's not commonly seen in the practice. Usually children are brought in a dire situation and do need emergency management, and they are always seen in the hospitals. But their number is not that large. Majority of them do come from the cattle camp residents. Measles do come in epidemics, and in fact, the control of measles is problematic, not only in our country here, even in America. Currently, there is an epidemic of measles in US, in America. And with the government of President Trump, he brought some problematic people like Kennedy, and appointed him as the Secretary of Health. He's somebody who doesn't believe in vaccines. So when he was appointed, he was questioned in front of the Senate committee, and these questions were raised and brought against him. And anyway, he just lied low. Now, there's a problem with measles in America. In America and in Europe, they use MMR vaccine at 14 months. That is the time they think, the antibodies against measles have gone down. But they have also rubella. The R stands for rubella, and then the other disease is mumps. We have mumps here, by the way. There's no season for it, but there's usually a time when we see cases of mumps, and I do think that the EPI should consider including the vaccine of mumps as part of the antigens in our EPI schedule for vaccination of children. Because moms has far-reaching effects, especially on the reproductive organs. This is one cause of sterility in the long run. So we need, to really look at this. Rubella is not so common here, but still, there are some findings in the assessment of some of the obstetricians with regards to some of the clients in the antenatal care. The findings show, the presence of rubella, but of course for children who do carry, the stigmata of infection with rubella, in the first trimester, we do not have much of them here. We don't see them. It's not really a problem for that, but still people can look into that and introduce the whole thing of MMR. The measles vaccine is given at 9 months because Africa, this is of course a WHO advice, because Africa is a continent, especially sub-Saharan Africa, is a continent of disasters. A good number of our children are seen in the camps. They really get a number of diseases which drops their immunity, and so they need to be given this vaccine earlier. That's one of the things, that the measles vaccine is given at 9 months. But at this month, the level of the antibodies is still high. The antibodies given by the mother to the child. The level drops after 1 year, and they are low at around 14 months. So measles is still a problem, and even now there's a campaign of measles vaccination going on in Juba Town, maybe in other areas. This is a disease that we commonly encounter, and it has got a lot of problems, especially in the community. The community still thinks they own, the management of measles. They will not bring the child who has measles to the health facilities to be managed. There are some taboos that surround the management of measles. So maybe it needs some kind of strong advocacy activity to really demystify some of the beliefs that are detrimental to the health of
Thank you.
our children.
Okay. Yeah. Thank you very much, Prof. That was quite a lecture. And Professor Hassan is very soft-spoken, says everything, if you pay attention, it's a point. So you could get tired of writing, yet you still have to write because everything he says is very important. And we just got a lecture on the trends, on what is common. He has mentioned that he's happy that we no longer see whooping cough. We also don't see diphtheria, but he cautions that there is mumps and it has no specific season, and appealed that it's important that we think about this going forward to incorporate vaccines for it in our EPI schedule. Those are some of the important things that he noted, and also rubella and the perceptions about measles. We just launched a measles catch-up campaign on the 24th last week, and that is because there are many children in this country who are yet to get vaccinated for measles, yet there is a perception, and we'll come to a pin later to deal with that and tell us in his own view what UNICEF is doing and what he thinks also could be done. But I want to go across, because there is Dr. Dut on the other side, the infectious disease specialist, who is also a neonatologist, but really invited to this in her capacity as an infectious disease specialist. By the way, Dr. Dut is the head of the pediatric unit at the Mater Hospital in Nairobi. South Sudanese are very good professionals, and they can work outside the country too. But we need them back home. let's not despair. She comes home often. She was here the entire February to help at the Juba Teaching Hospital, while also having to leave that side. And as women, we understand why she has to live in Kenya. That's a story for another day. Dr. Dut, can you hear us? I want you to take us from where Dr. Hassan has left us. And we talk about disease control, having discussed the trends. What are the, please tell us about how the vaccines that we have for children in South Sudan, not just South Sudan, but you could think about sub-Saharan Africa or even the globe, how they have contributed to controlling infectious disease outbreaks in childhood populations over the past decade. But most importantly for South Sudan, Dr. Hassan or Professor Hassan has talked about where we've come, the fact that we no longer see whooping cough and diphtheria, but I believe that from an infectious disease perspective, you can delve into how these vaccines or vaccines that are launched so far have contributed to controlling infectious disease outbreaks in childhood populations over the past decade. So over to you, Dr. Dut.
So thank you very much, Dr. Emily. Good afternoon, everyone. It's my pleasure to be part of this panel. So when you look at the childhood immunization program or the outbreak of most of the childhood infections, so we come to the how vaccine control outbreaks of what? Of an infections. So as we know, vaccine control infections. That why it's a must for every country or every community to encourage our children to be vaccinated. So how does this vaccine work? It's normally what? It's build immunity. Once your immunity is built, it prevents the spread of the disease. So when the vaccine is given to a child, we try to stimulate the child's immune system to develop her memory. So we'll have an idea about this antigen when the child get what? That's antigen. So let me take you an example. When the child is immunized and already the body has an idea about that antigens, even if that baby or that child get that infection, it still will get it in a mild form. And it will be a significant reduction for that community within or that children within that area to spread the infections. That's why we encourage immunization. So not only that one, but the vaccine itself is play a big role in what? In reduce the antimicrobial resistance. For example, I take an example of the measles vaccines, and measles vaccines has been a serious burden in South Sudan. We are not able to achieve or to control outbreak of measles vaccine. So we need to ask ourselves, why are we not able? Every now and then we have an outbreak of measles vaccines. Because when you look at the vaccination in South Sudan, we're still not able to achieve what we are supposed to achieve. For us to have control of measles in South Sudan, at least we have to achieve 95%. By the time most of the children in South Sudan immunized and we have reached that 95%, automatically the community or the children within that community will develop what's called the herd immunity. So once we have developed the children within the community herd immunity, so there will not be transmission of what? Of the measles, even if those ones who are not immunized. So this is what we are really facing in South Sudan, because we lacked, there is this one that the parent are not, the lack of trust in the health providers and in the vaccine itself. We need to work so much on the vaccination. So this measles is one of the most important the way of how we control the disease, especially when it's come to the outbreak among the children. So when you look at the South Sudan actually has done very well in terms of immunization to reduce no child in South Sudan will die from vaccine preventable disease. So I will not go too much to the history because up to 2013, South Sudan was still giving the DBT vaccine only. In 2015, South Sudan introduced pentavalent vaccine, and it was a very good move for South Sudan to introduce the pentavalent vaccine because of the Haemophilus influenzae as a cause of meningitis and pneumonia among children. And in 2021, South Sudan already introduced the inactivated polio vaccine, but it's still South Sudan in a red zone of we're still getting some polio. We're still getting some poliovirus circulating in South Sudan. And recently, South Sudan has already introduced malaria vaccine, as malaria is the leading cause of the under 5 mortality in South Sudan. As we know, South Sudan has been experiencing prolonged humanitarian crisis and suffer one of the world's highest child mortality rate. And South Sudan has only, if you look at the World Health Organization statistic that was released, that South Sudan for last year, South Sudan was just able to reduce the mortality related to pneumonia by 3% or less. And this 3% or less is insufficient for South Sudan to achieve the sustainable developmental goal of ending preventable child deaths by 2030. As we know, pneumonia and diarrheal disease, those two are the leading cause globally, and the 5 mortality, and in South Sudan, is still the leading cause of what? Of the under 5 mortality. But with this introduction of this new vaccine, the PCV, the Pneumococcal Conjugate vaccine, and the Rota vaccine, South Sudan marks a major milestone in South Sudan to ensure that no child dies or becomes sick because of a vaccine preventable disease. And with introduction of these 2 vaccines, we'll be able to see a significant reduction in what? In hospitalization among under 5 and deaths, mostly associated with pneumonia, sepsis, and meningitis, and with a diarrheal disease. So South Sudan is still, with this introduction of the PCV and rotavirus, could prevent nearly around 60,000 deaths between 2025 to 2030. So we need to work a little bit extra mile on how we can encourage our community or our society in South Sudan so they can bring children for immunization. It's really is everyone work. So we need to work as a team. How can improve the immunization status of children in South Sudan, for example, for us, not to get every now and then an outbreak of measles. So back to you, Dr. Ari, unless if there is more clarification. Emily?
Yes, thank you very much, Dr. Adut. I want to stay with you briefly and quickly in less than a minute. If you listen, you heard Professor Hassan say that one of the vaccines he recommends should be introduced on our schedule, according to the trends he has observed, is the mumps vaccine. And we already said, you missed a session earlier where the National Ministry of Health EPI manager mentioned here that we already set for the introduction of the 2 vaccines, that is Pneumococcal Conjugate and the rotavirus vaccines. But in your perspective as an infectious disease specialist, are there other new vaccines or updates to existing vaccines on the horizon that you see could significantly impact childhood illness prevention in South Sudan, so that you recommend them? By the way, in the room, we have the Director General for Primary Health Care seated here and listening keenly. He's taking in all this information.
So if you ask me as an infectious disease and expert, I would recommend like 3, 4, 5 vaccines. The most important ones is meningococcal meningitis. So as we know, meningitis is the leading cause of what? Of still of mortality in a country like South Sudan, and it's the leading cause of what? Of the childhood disability. Once the child with meningitis is not well treated, it is well not managed well. So meningococcal meningitis is very important. If South Sudan could consider that to be introduced in as a part of the routine childhood immunization in South Sudan, will actually improve a lot. And we talk about the cholera vaccine. So South Sudan is a country where we talk about an outbreak of cholera, as it's not because of a lack of vaccine, but we have so many other factors could be considered for us to prevent the cholera outbreak because of lack of the good hygiene, sanitation, so lack of safe drinking water and all that. So maybe South Sudan still could consider oral cholera vaccine to be introduced, because if you look at the mortality, you'll find that the under 5, are the one dying mostly whenever there is any outbreak in South Sudan, whether it's a meningitis or cholera. This is the second. And then we talk about the hepatitis. South Sudan already, the hepatitis vaccine is given as a part of the pentavalent, but South Sudan is one of the countries has high burden of hepatitis B vaccines. So I think we need to advocate for the birth dose of hepatitis B vaccine. If South Sudan can introduce the birth dose that they can be given within 24 hours, I'm very sure that vaccine would have reduced or like a perinatal transmission by almost 60%. For most of the newborn, will not get that. Hepatitis B is common in South Sudan. Hepatitis B, even sometimes we don't know even the status of the patient, and then you can see sometimes we can still give it because we have in South Sudan, but you can see the patient has to buy it. But we don't want patient to go and buy a vaccine when the government to provide it. So it's been more easier for the people in South Sudan or to access. We talk about the accessibility and affordability of the vaccine. Even the cholera vaccine can still be made to be affordable and available for everyone, so to access it. So we talk about rabies. I've seen so many cases of rabies in South Sudan. Rabies is a very serious, it's a very serious disease in South Sudan, and the victims are normally children between the age of 5 and 14 years. And it's something we can prevent it with a vaccine. So it's a vaccine preventable zoonotic disease. So I think we need to work on how the government of South Sudan can provide rabies vaccine, because rabies vaccine in South Sudan people go and buy. So it's still accessibility and affordability is a big problem. Hepatitis A vaccine. Hepatitis A vaccine is very important for the kids. It's one of the it's more of hygiene when you talk about the hepatitis A vaccine, but children can get a severe form of the hepatitis A vaccine and can die high risk of the liver failure. It's good if the government could consider some of the vaccine, but if you ask me, I would say government of South Sudan should consider the meningitis vaccine. It's very important, and the chicken pox and the mumps, like my colleague Professor Hassan have just mentioned. Mumps, you keep seeing mumps a lot in South Sudan, and one of the complications of the mumps is affect their reproductive health system. So we can still introduce the mumps, rubella, MMR, the 3 of them, to the South Sudan immunization program. So now, these days, most of the countries are talking about the human papilloma virus, the HPV. And the HPV is mostly given to girls and boys between 10 to 11, 12 years. So because as you can see, like cervical cancer is the leading cancer worldwide, and in sub-Saharan Africa is leading. So by providing the HPV to our girls in South Sudan, we'd be able to prevent them later on not to get, or to reduce the risk of getting the cervical cancer later on in life. Dr. Ari, back to you, unless if you have something you would like me to add.
Yes, thank you very much. Continue to stay with us. That was very useful. Some of those vaccines, the cholera vaccine was introduced as a result of the outbreak, but we have seen uptake remains quite low in some places. Even here in Juba, now we have even a huge burden at the moment that we are grappling with. But of course, we know that has to be matched with water, sanitation, and hygiene related efforts. I want now to move to the clinical officer, and Mangui, you're going to respond to these questions with hope that you're going to tap into your rural child health experience. We believe you've handled children in a more rural setup compared to Juba. And so in those circumstances, what are the main challenges you have faced while participating in implementing vaccination programs? I am deliberate about you preceding UNICEF and WHO representatives because they will have to take on some things as you speak. So what are the main challenges you have faced while participating in implementing vaccination programs in rural communities, and how have you overcome them? Maybe things that people don't hear often when you're down there.
Yes, thank you so much for the opportunity. Though we have seen the coverage of immunization in national level, let me say at the states, where people in town will be able to receive more compared to those in primary health care. Regard to my experiences that I have gone through in those communities, are so many challenges, whereby up to now, as I speak, some children have grown up to the age of 10 years without being vaccinated. This has cost them a lot, and as we gathered here today, I urge ideally, if we were to also have community leaders amid this gathering, it will be the right people to take some of the vital information that we shall be passing to each and everybody. Let me go to some of the challenges that I have encountered in due course of my experiences in those PSCC. I have got so many, but I will make it short. To begin with, we have seen there is limited health infrastructures, especially in our communities. That's today in Boma level. You get a facility that has a limited structure to accommodate what's to be used for vaccination. It has seen that a lot. We have also accessibility issues, especially poor roads, a lack of transport, and long distance. That distance some families to access, especially when you go to upper end of Eastern Equatorial State. As the director have mentioned, the other communities, it's hard to reach them. How do we expect such to reach? This is a question we shall come to answer later. And then we have also seen shortages of skilled healthcare workers. Rural area often face human resource shortages. You get in a primary health care being managed by one nurse. At the same time, the service is needed to give drugs to clients who will be coming. At the same ones to go to community and vaccinate. In this manner, what do you expect to happen? Meaning it is still a great challenge that we have seen in those primary health care up to now is still happening. We have also a challenge of cold chain problem. You know, to maintain a cold chain program, it needs electricity. I'm very happy with the UNICEF. Previously, they have been donating cold chained fridges that uses solar, of which it has not been reached to other primary health care. And having vaccine carrier, it cannot store vaccine for long. We talked about the potential of vaccine previously, that at least they have to be maintained in a freeze so that it maintains its potency. But once it is transported using vaccine carrier, it cannot last for more than 4 hours. It can easily melt up, and its potency will be lost. We have low health literacy. Many communities have failed to understand the meaning of vaccine. Others perceive as bad practices in the community. We have seen many communities refusing to bring their children for vaccination. How can this information reach to them? Meaning there's still poor understanding of this word vaccine to the ears of our mothers in the communities. We have seen also there's issues with geographical locations. So some communities that are far away from health centers. Up to now, other health centers have been closed due to the continuous civil war in our community, and of which they are supposed to receive also vaccination. And therefore, as we talk, they are still having no health facilities where this vaccine can be taken to. We have cultural belief and heritages. Traditional beliefs may cause fear or rejections of vaccination. Let's take to religions. Still, we have seen there is a battle between vaccines and other new dominations in the area of religions. Other religions still, they are refusing their children to be vaccinated. As a medic, these are the things that we have been facing in our community. And still the battle is still continuing. a question later will come, what should we do? We also face challenges, language barrier. You get some nominates being sent from the national level. They go to the primary health care level with the language which the community cannot speak. This has been also a great gap. Passing real information to the ears of a community has lost meaning for them to take up these vaccines. We have political and administrative gaps due to inconsistency in our political system. You get today, Mr. So-and-so is in an area, again tomorrow is taken to another place. It has also hindered the connections between these communities, linking them from the Payam to county to national level. It has been a challenge. This is what some of the challenges that we face as we who are handling immunizations coverage within the village and rural areas. I think that is some of the challenges that we have faced. We managed to also link some of the way how we can at least enforce these communities to get involved in supporting the program for EPI, whereby we said the best thing that we can do as a team is to partner with our community leaders, because we know these are the people who are always there in the community. Once we engage them, they will give us a very good image on how important is a vaccine in our community. In other places also we have been holding series of community meetings and dialogues, creating space for open discussion where community asks questions, share concerned, and get reliable information for health from the expertise. This has also helped them. The use of peer educators, train community members to educate others. On vaccine, people often trust information more when it comes from peers. When we talk of peers, those ones who always stays within the community, especially our parents. The little when we train them, they can be able to pass the information clearly to those ones whom they stay with. Participatory planning. Having involved these community members to participate in area planning, especially the strategy to ensure they meet the local needs. We actually urged, at least, like when we are going with the program for immunization, we shouldn't be planned from where we are taking it. Let it be planned from the area where this vaccine is taken, so that the implementation can be easily done. But when it is already planned, you go and expose, there's always resistance there. Cultural appropriate messages. We said previously I talked about the language barrier, meaning we should elect people who are taking this vaccine should be nominates who can speak the language in that particular area. Meaning if you speak to me in your dialect, I will understand much better compared to somebody who borrows the language and translates to me. We also be able to mobilize what we call outreach and pop-up clinics, bringing the vaccine nearer to the beneficiaries. We shouldn't be calling them to come, but we take it to them, meaning it is going to be door-to-door vaccination. In this manner, it has partially increased the coverage within those various places. We also got what we call feedback mechanism. We take vaccine, sometimes we don't follow it up, the feedback, whether it has been taken perfectly or it has not been, it is good or it's bad. This feedback helps you to understand what is the community needs and what do they don't want. Visibility and vaccination efforts. When we talk of visibility, the other people understand best by seeing. For us, sometimes we understand by hearing. Meaning when we are taking these vaccines, let's have posters that demonstrate where it is supposed to be injected and how long should it stay after being opened. But in other rural area, we cannot access these posters to tell the community this is the vaccine and it is given in this manner. It has become also a challenge, but having this, it has improved. We have a transparency and honesty. Let's be sincere to our community about the risk, the benefits, so that they can understand the importance of this vaccination. Otherwise, I thank you so much for the opportunity. I beg to stop here.
Thank you very much, Mangwi. That was very elaborate. And now going to Dr. Eric. Dr. Eric, as the head of the WHO Country Office Immunization Hub, you've listened to the experts, the infectious disease specialists, the a well-experienced consultant pediatrician and here on the panel, and also a practitioner who has shared a number of things. And so it's about time we check the WHO strategies, whether they really respond to these trends as have been elucidated by the experts and also the practitioner. So what are the current national strategies and initiatives that have been put in place and are being pursued by WHO to combat child or vaccine-preventable childhood illnesses? Keep in mind what has been said so far. And because the audience, both here physically and online, is intrigued, I believe, to understand whether really, considering all that has been said, the WHO country office is responding to what is really happening. Thank you.
Thank you, Dr. Emil and colleagues. I will start saying the WHO country strategy is the national ministry strategy for immunization. We work with the ministry, with the EPI team, to address all those issues. The ministry lead and partners WHO, UNICEF, and support from Gavi for the implementation. The national strategy currently, there are, I think, 4 or 5 lines which I want to highlight. The first one is the routine. The routine immunization, where we use, as George mentioned, the fixed site outreaches and dry season. If the routine is not strengthened at the health facilities, as my colleague on my right side mentioned, the issues he highlighted which affects the routine immunization, and those children will not have access to vaccines. The second, there are initiatives. Let's say the first one is the polio eradication initiative, the measles, rubella initiative. We have also the meningitis, yellow fever initiative. And all those initiatives are there to get vaccines in the country. We know everyone highlighted the issue of funding. Funding is a big issue. We see vaccines in the country, but there is a big chain behind that, led by Dr. Atem. You can see vaccine here in the country, but there are many other processes which has gone back. We don't see. We think it's a free vaccine, but in reality it's not a free vaccine. There are so many effort, processes, negotiation to get those vaccines in the country. And those I mentioned, the initiatives, they are there to support the country, every country, especially sub-Saharan countries where resources are limited. The other initiative, it's the cholera elimination strategy, also support countries to get cholera vaccines. Currently, the strategy which is there is the reactive campaign. The preventive campaign, it's quite difficult given the global shortage of vaccines in country. The other strategy which the previous speakers highlighted is to reach the zero dose children. There are missed opportunities and missed communities. Those children are using different strategies. The first one which are using currently, the Ministry of Health is using, is the big catch-up campaign. Those counties with high zero-dose children, there are around 30 where the children are missing their first dose of vaccines. And that leads really to the outbreaks. It's why we see, if you see the coverage in those counties, it's where we see most of the outbreaks, especially the measles, and you see other outbreaks and related to hygiene and sanitation. The big catch-up which is ongoing, it goes as in phases, where to support and reach all those children, as he mentioned, to go to the communities, to reach those communities where they are, not because of the health facilities perhaps is not functional, because they had to reach areas, because of the displacement, because of the flood. There are other many issues which all those children are not getting vaccinated. The last approach, which also I will say the strategy which we consider, is the integration in all what we do daily. If we have a nutrition session, also we encourage the health care workers also talk about the vaccine, the importance of the vaccine, the benefit, the barriers, and in all the outreaches not related to vaccines, because we have nutrition outreaches, we have other NTD outreaches, and we also have other projects which are run by the Ministry of Health, supported by partners, to have this integration. And this will increase our coverages and to avoid many outbreaks. The last one which I will highlight is the introduction of new vaccines. Currently, South Sudan, this second quarter, will be introducing 3 vaccines. The measles-containing vaccines, second dose, the PCV as the Pneumococcal Conjugate vaccines, and also Rota vaccines. And last year, the country introduced the malaria vaccines, and this year, for 28 counties, this year they will scale up the other 52 counties. Those are new vaccines, and we need the healthcare workers' support. As our colleague mentioned, the message we need to give, the visibility, and we don't want to see what happened when we started the introduction of the malaria vaccines, the dropout, and we want to increase our coverage and prevent, as the colleagues have highlighted, the burden of malaria, the leading cause. As Dr. Tem mentioned, the pneumonia, the second cause, diarrhea diseases, the third cause. As we are having all these introductions, and we need our healthcare workers to be trained, the supervisions, and we don't have the dropout. These are not single doses like cholera. They will be having subsequent doses to prevent all these disease outbreaks. Thank you. That's just the key summaries of the current strategies used by the country to prevent the disease in childhood illnesses. Thank you.
Okay. Thank you very much. I want to move to Apin. That was elaborate. It's a 4-line strategy, routine, immunization, 0 dose, children, all those missed opportunities, big catch-up, and the new vaccines. And by the way, for the healthcare professionals in the room, we already have the Pneumococcal Conjugate big catch-up going on. It started on the 16th. The Director General is in the room, can confirm. Those are the dates that have been picking from our technical working group meetings. So this is information that we can carry on because we are critical in continuing awareness to the communities. But I want to turn to the Social Behavior Change Officer of the UNICEF Country Office, Mr. Apin Kulel. We've listened again to the experts. We've listened to a rural practitioner. And of course, the WHO has said this is the strategy. But there are healthcare professionals in the room, and we are here today because there is a general agreement that we are quite detached from the immunization program as healthcare professionals in terms of championing immunization programs in our country. So the question is, what strategies have been applied to try and engage healthcare professionals as part of strategy to advance the immunization program in this country? We know that UNICEF is part of the huge machine that runs immunization programs, not just here in South Sudan, but everywhere you run the cold chain, the logistics, you're the ones who receive for us, but there is also more. You deal with the social behavior change, the awareness. How has the strategy taken care of this important thing that healthcare professionals should be engaged and should be champions? And what have been the challenges in terms of that part of the strategy?
Thank you so much. I will not talk much. I think colleagues have issues to do with behavioral related issues in terms of immunization. So looking at how we support the EPI program, not only EPI, also even other health related program, is first of all, when there is a new vaccine that needs to be introduced in the country, you need to first run an evidence-based, quick, rapid study to understand, do we have within the community, do we have people who really might have heard about these vaccines? Do they even know the importance of these vaccines? It is that quick, rapid study that will give you an idea of what are you going to deal with if you are going to introduce the vaccine. I will be doing reference to some of the vaccines that we have already introduced in the country, like malaria vaccines were introduced last year. We had to do a quick surveys to make sure that do communities understand about that vaccine. Do we have, within the population, do we have some people who might have heard about the vaccine? Do we have people who have that risk behavior that malaria is so risk to the children and also even to elderly? And if that vaccine is brought into the country, are people willing to take that vaccine? So when we ran that, it gave us a good coverage in terms of acceptability. It was very high. It was around 70 to 80%. When the remaining were saying, I can take it, or my child can take it, but I need to learn more about that vaccine. So you could see that portion of population is also quite important. So when we talk about behavioral issues here, there are also other factors that can affect that behavior. So for someone to take that decision to take that child for vaccination, there is that information that this vaccine is so important. And there is also other factors like the enabling environment. Do we have those vaccines? Are they accessible to my location? And how am I also prioritizing that child to be vaccinated when I have other issues that I'm coupling with, like the life-saving issues? Like, for instance, some mothers may default not to take the child for vaccination because they are busy in the market to make sure that they make a living for other children. So coupling with all these issues, it is all about if our communities really understand the importance of all these vaccines, what do they do to us? What is the impact? That is where we would really achieve something. So for malaria vaccine, we did that survey, and that survey was what informed our strategy. What are the activities that we need to do in terms of who should we engage to inform who? Who should support us in the process of launching and in the process of making sure that the dissemination is carried all over. This is where we come up together with Mama Mary, because she's the one leading this component, by the way, where we came up with the strategies, thinking that we need to have a big launch that need to be endorsed by higher people. We also need to engage the community stakeholders, like the community leaders, the community influencers, and also the health profession was also very key in this. I would mention where we were having a lot of challenges when it comes to health workers' understanding of some vaccines. You see the misinformation or the misperceptions coming into the country regarding vaccines. Actually, some of it starts with some of the health workers. The understanding of some vaccines, the understanding of some health workers about vaccines is quite low sometimes. It was an issue with COVID. When COVID came in, the vaccine itself, yes, we may not blame people a lot, because with COVID, there was a lot of unknown that need to be known. And when the vaccine was introduced, the first beneficiary or the target group was supposed to be the high-risk group, which include the health workers. When we roll out in this country, it was disaster. The first one. I remember when Dr. Tem, the rest of us actually launched this campaign, it was disaster, especially from the side of health workers. The acceptability was very low. And what would it indicate to you, like if you are the health worker treating people and there is a vaccine here that need to help people control some diseases, and you are the first to be hesitant to go for that vaccination? What will it tell to a mother in Fangak or Kobo or Raja where they know nothing. They believe in us. Whatever we are saying to them is what they believe in. So this was quite challenging in terms of this. So this is where I would say this forum today is quite touching, and it is at the very right time. And I think we need to tap into such engagement, especially with the health professional bodies, to make sure that we promote any vaccine that we are introducing into our system. So these are issues. With COVID, it was quite disaster until we had to make a lot of engagement. UNICEF, Ministry of Health, WHO, all coming out to different health facilities to carry out different sessions to make sure that health workers themselves first understand what these vaccines is all about. There were a lot of infodemics around it. It's the same thing even when we also introduced malaria vaccines. There were a lot of infodemics. Although we had 75% acceptability that if that vaccine is brought, I will take my child for vaccination. Still, there was a lot of infodemics, and you see these infodemics may start from the health workers' bodies or maybe from outside, and when it slips into the country where we have around 70% of people who are illiterate, that would really cause disaster, because they believe in what semi-illiterate and illiterate people are saying. And that is where we have a lot of issues. When we introduced malaria vaccine last year, it was okay, it was launched here, people were saying it will be accepted. But somewhere in 2 counties where we were supposed to launch, the county authorities said, no, we don't want to launch this. We need to learn more about this vaccine. Why are they bringing this vaccine? Maybe they are targeting to do what? To kill us. Or maybe there is something linked to reproductive things. And that was the main problem when we launched also COVID vaccine. There were a lot of misinformation around reproductive health. And you know, human beings, once something is touching your productivity, that is where you become so sensible. And that is in the first campaigns that we carried out for COVID-19 vaccination, they were really disaster. They were really having a lot. We had to have a lot of intensive engagement of professionals, looking at the community leaders, being sensitized. We carried out the community dialogue meetings. There were a lot of campaigns over the radios. They also had to go even into the religious institutions that we have in the country, because there were some churches that were pushing back, saying, no, we don't promote, like asking our congregation to go for these vaccines. So for these ones, the strategy is there, and we are trying to learn from the previous vaccine that we have introduced, and that is where we come up with some of the strategies that we are laying out for PCV and rotavirus. So it will be launched in all the country, in all the counties of the country, and we'll also have like some community engagement activities that need to happen, where we need to engage with the health workers to make sure that they send out that message. You know, community health workers are the ones that interact a lot with the population, especially with the caregivers. With the EPI surveys that we have always done, there is consistently information that is coming that sometimes some of the vaccinators, some of the health workers, if they don't have a good scope of knowledge about that vaccine, they don't speak properly to the caregivers to emphasize the importance of that vaccination. So these are issues that are coming. It is not only that, but there are other factors as well. The insecurity, the traditional beliefs are all coming in, as I say. So all of us, I think we have a lot of work to do to make sure that we improve our routine system. All of us need a lot of work to do in making sure that to the communities that these vaccines are so important. They are not brought to kill anybody. They are brought for the benefit of our children, for our country. Thank you.
Thank you very much, Apin, for emphasizing that the scientific evidence is there that vaccines work. Healthcare professionals are critical in championing and spreading this message instead of being impediments to the consumption of life-saving vaccines. And we are here in the room, we are listening, and so are many others who are following us online and others who will catch up with the proceedings of this symposium. I want to go across the room and get to Dr. Adut. Dr. Adut, you'll be answering the last question and also take the opportunity to make your parting shot, and then I return to the panelists who are physically in the room. Earlier on, as you listened, there was, or you missed that part, but there was mentioned by one of the speakers, and that is the EPI manager, that one of the challenges South Sudan has had is that because we have to absorb a lot of refugees, or rather you could call them forced migrators into the country who we had not planned for on our vaccination schedule in terms of the number of vaccines. What has happened is that we've not been able to meet our targets. For example, because of the war that has happened up north in Sudan, we've had the influx of more refugees, and that has meant that travel across borders has in a way continued to affect. We saw what COVID did, that was how it spread. There are also other vaccine preventable diseases that are actually traveling is a risk factor for, including some childhood illnesses. But we would, building on that, Dr. Aduta, we would like to know how, in your perspective as an infectious disease specialist, you see the increasing global travel. Some of it is actually forced, as we have seen, that for us as South Sudan, we unfortunately might continue to receive these forced migrators. There are very many in Reng County as we speak. Some of them are our own South Sudanese as returnees, and we have to grapple with that. So when we have that kind of thing happening, in your opinion, how does it influence the spread of preventable the spread and prevention of vaccine preventable diseases? I mean, how does that migration really influence the spread and prevention of vaccine preventable diseases in children? If you can respond to that very quickly and then make your parting shot based on what you have heard and based on the theme of this. It could be a call to action in your own perspective as an infectious disease specialist, and then we can gladly release you. So over to you, Dr. Adut.
So thank you very much. So when it's come in, you can see immunization, yes. With immunization, we'll be able to control the outbreak of a disease and all that. But what is beyond vaccinations? Because it's not only vaccine can control the spread of the disease. We need to consider other factors. In a country like Sudan, with the recent outbreak of cholera. So what are those factors we could consider for us to what? Reduce the outbreak of what? Of the vaccine preventable diseases. It's like we need those factors, like example, malnutrition, poor hygiene practice, unlimited access to safe drinking water and sanitation, maternal education and low socioeconomic status, the poverty and early child marriage. Those are all factors. If you can address it, they are very crucial for prevention and control of these diseases, example like diarrhea and pneumonia. So when it comes to malnutrition, so as we know, malnutrition normally weakens the immune system, making our children more prone to what? To get pneumonia and diarrhea. So what can we do in case of that one? So that's why we normally advocate for what? For the exclusive breastfeeding within the first 6 months, and then introduction of what? Nutritious, weaning food for us, what? For us to reduce what? The risk of our kids getting malnutrition, so we can put them at high risk of what? Of getting pneumonia and diarrhea, even if they were immunized. If we don't consider malnutrition and all that, the sanitation is still at high risk of getting what? Vaccine preventable disease. When it's come to the poor hygiene, sanitations, as because of lack of access to clean water and sanitation, along with poor hygiene practice in South Sudan. This one facilitates the spread of diarrheal diseases and can worsen what? Pneumonia, because all that's an introduction of infection to what? The child body. So we advocate for what? For the clean water, and for what? For adequate sanitation, And for what? We need to really advocate in South Sudan for the hand washing practice, hygiene. We should encourage every person, even the children in the school. You should be talking about it every day, especially schools. The importance of washing hands with soap after using the toilet, before preparing the food, after touching high infectious service and all that, yeah? So we talk about the environmental factors. We need to keep our environment very what? Very clean. The hygiene has to be what? Adequate for us to reduce the risk of what? Of a spread the infection from contaminated services to our children, our children and all people living with us in the same place. Maybe the indoor air pollution is a very important risk factor for what? For spreading what? Or worsening the respiratory infection and increase the risk of what? Of pneumonia in our children. Overcrowding, like what is happening now with the refugees that's coming to South Sudan, the risk of pneumonia and the diarrheal disease and the cholera. That's why we have an outbreak of cholera due to what? To the poor sanitation. So the limited access to health care. So with the refugees that are coming to South Sudan and all that, and as a South Sudan, we are still, I can say that our health system is still fragile, and with more people coming, it's still need more work for us to do. So now the limited access to health care is really a big barrier. So this one will not help us to diagnose and treat our children timely when it comes to pneumonia and diarrhea. And pneumonia and diarrhea are the leading cause of what? Of deaths in under 5 worldwide and in South Sudan. We don't treat very fast, they die very fast, especially in diarrhea and dehydration. So we talk about the poor healthcare seeking behavior. We found that limited awareness about the signs and symptoms of pneumonia and diarrhea and the lack of trust in healthcare provider. And all this can lead to delay of treatment. So if we are able to address these broader factors, together with the scaling up vaccination program, so we'll be able to reduce the burden of childhood pneumonia and diarrhea in South Sudan. And for us to reduce this burden, this one requires a multi-sectorial approach involving healthcare, education, water and sanitation, and social development intervention. And thank you very much. And back to you, Dr. Emily.
Thank you very much, Dr. Adut. It has been a pleasure having you. In what we have heard, I have picked something very important in terms of PCV and Rota. You have, in terms of in responding to the question, said that what actually migration, and in our case forced migration as it is, leads to is the overcrowding that we see in the refugee camps or in the internally displaced persons camps. And that then exacerbates the spread of diseases, including childhood illnesses. So as partners sitting here in the room, UNICEF, WHO, South Sudanese Women in Medicine, Access for Humanity, and the rest, and the distinguished healthcare professionals, it sounds like when we are prioritizing vaccination this time around, we have to make sure that the vaccines get to those places without fail, if they have to fail to get anywhere else in the country, because those are hotspots where spread can happen. So thank you very much, Dr. Adut. It's been a pleasure having you. We totally understand that connecting to a blended session like this can be a challenge. You can continue to stay with us if you wish. Otherwise, adieu to you, and we see you next time when we have an occasion like this. So I want to turn to Dr. Eric.
You very much.
You're welcome. I want to turn to Dr. Eric. We have listened to Apin talk about how us healthcare professionals are actually, while we can be the promoters of vaccine consumption, we've also been quite a pain, and it was evident during the time of COVID, and those have been the challenges. But recently we also saw, as you have noted in our meetings, that we had to postpone the introduction of these vaccines. The EPI manager was here, narrated our journey having started as far as 2021 when the conversations about introducing these vaccines started. How Gavi then supported, got us a consultant, we submitted and we lodged an application, approval got done in July 2024, and we are here. We thought we were set for April We've pushed to May. The rainy season is here. The pediatricians are worried. I am also worried. Everybody should be worried. The question is, there's this reality about us that is to be confronted about healthcare professionals, possibly being an impediment, but what have been the really negative contextual realities that have affected this timely introduction of PCV and rotavirus vaccines in South Sudan, and what measures have been taken? We can say that yes, we are set, like we have said since the beginning of this year, but there is also the anxiety that what if May doesn't happen? What if, God forbid, what if it should not happen? So what have been those realities and what is being done to address them so that we assure the healthcare professionals here, the citizens following online, that we are not postponing any further. The children of this country must be gotten rid of pneumonia and diarrhea. Thank you.
Thank you. Thank you. I think I'll say the healthcare professions, as all of us here, we have that background. And secondly, I might be a healthcare worker and then I'm community leader where I'm living. That has an impact, what I do in the community and in the healthcare facility. And I might be, again, a pastor, priest. Those are key functions in our society where we live every day. And if you are here, I'm here, and I'm listening to this introduction of new vaccines, which we are talking about, PCV and Rota and other vaccines, that has an implication in where I live, the questions I will receive. I'll come back to the realities and negative impact to the introduction. There are different steps for any introduction of vaccines. As George mentioned previously, I will not go to that, but the impact, which really some delays in the implementation, especially my colleague highlighted some of them, but I will go to the level of the high level discussion, which I will put is the availability of the vaccines in the country. The time the vaccines in the country delays, or the implementation, you have to push. Secondly, is to work with UNICEF, because the global supply for vaccines in any country, to have those vaccines in the country. Secondly, is all the healthcare workers, not missed any, all the facilities, because these vaccines, they are going to be in routine. All the healthcare professionals, from a doctor, nurse, clinician, clinic officer, at the level even of the Boma health workers, to be informed about these new vaccines. The time we are not set to that, even if we introduce, the dropout will be very, very high. The other is the financial and political commitment. The time the finances are not meet what we need from the healthcare workers, from the health facilities, that's another challenges. We have heard about the co-financing, but Gavi, luckily for countries like South Sudan, is still giving a waiver, but it's not going to continue with a waiver. When that political commitment, which Dr. Tem always in all the meetings, he emphasized on it, to have the not donor dependent. We have really in Africa, most African countries, we have donor dependent to vaccines, and really they are very expensive, and we have a very low domestic investment in vaccines, procurement, supply, distribution, even at the level of the implementation at the health facility. And again, I would say there are so many mitigation measures which are supported by partners and also Ministry of Health. That's the capacity building for healthcare workers from the low level at the national level. The supervision is the key, because the time we send these vaccines to the health facilities and we don't go and look if those vaccines have reached If that child from that has not been vaccinated, that also is a waste resources. The other thing, which is the adaptability of the country context, the conflict, the flood, displacement, and also the influx. South Sudan now is the first country in Africa with many returnees and refugees, more than 1 million from Sudan. That also, it affects the programmatic approach of the EPI program. Because if, let's say we have planned, as Dr. Tem mentioned previously, planned 2 million doses for 2 million children, and we receive more than 500 children from any other conflict country, that will affect the programmatic, the logistics, even the procurement of the vaccines, which also impact on the financial of the implementation of this introduction of new vaccines. And also the distribution, because if we have the Upper Nile part, Renk, Malakal, and Northern Barghazal, where we have many children from Sudan, the distribution of the vaccines is going to impact other counties which have also the children to get vaccines. Because the more, if you look back, when you check the health data in Sudan, they have not been vaccinating. There is no vaccination going on since like the last 2 years. And meaning those children, they have missed their first 2 years vaccines. When they come, we are really susceptible to get the outbreaks at any, either measles, either meningitis, either yellow fever, either all those are really preventable disease outbreaks which we can have. We are lucky also, we are still with support from the Ministry of Health, supported by Gavi, to get the vaccines even for those returnees and refugees. But it has a lot of implications in the implementation which has planned and what we have to do. What just I will say lastly is to have the healthcare professionals advocating for us to avoid the misinformation about the introduction of new vaccines. They are key. The second, the vaccines are available and they are working. The time, always we have those who have done the public health school, the vaccines is the most cost-effective tools to control any disease outbreak. Very cheap when you do it. Look, if we had like preventive cholera vaccines, we will not be having the cholera outbreaks how we are having it in the country if there was a preventive campaign. Because there was no preventive, now we are in a response, it's most costs than a preventive. If we do well our measles follow-up campaign, our PCV, we may have like 5 years or 3 years without an outbreak, which will save for the country, also for the Ministry of Health, will save the time to focus on other issues, the health, because of the context of the country. The last one is the financing of the vaccines. It's the advocacy. We are healthcare professionals. Where you go everywhere, you have to put this. The country, we should put really the financing for the traditional vaccines. Thank you. Over to you, Amen.
Thank you very much, Dr. Eric. I believe those were also partly your parting shots, but if you haven't made them, I could give you a minute to make your parting shots. That's okay? Yes. So a lot, he has said a lot, but for us as healthcare professionals listening, he's really appealing to us that we have to be supportive of these programs. But most importantly, he also talked about the fact that in the community we wear different hats. We can be religious leaders, at the same time medics, at the same time community leaders, and sometimes we also have access to policy elites and decision makers. And there's an issue that has been mentioned by almost every speaker here, which is vaccine financing. Financing for vaccines by ourselves as South Sudanese. When I say ourselves, it means us and our government is almost non-existent. We are being supported by partners. So we have to be advocates as we ought to. That's part of what being healthcare professionals calls us to do. to continue to advocate for vaccine financing to be sorted out as a problem in this country, because it's a serious contextual reality. I want to turn to the clinical officer, to Mangwi, and ask you to make your parting shots, because you actually answered all the questions that were posed to you for this panel, gave us what your experience has been in the rural areas, the challenges, and what innovative tailored approaches have been employed or could be employed to actually deal with the challenges that you narrated. But now, having listened to everything, but also in your capacity and with the experience you have, make your parting shots in a minute, and then I move to Professor Hassan.
Yes, thank you so much once again for the opportunity. However much we talk, as earlier before I said, issues to deal with vaccinations is in the community. And we need to engage the community leaders so that the coverage of immunization is taken up to date. As we teams who are on the ground, we have seen a lot of challenges, how we can get involved of these communities members. There are so very many strategies that we can employ to see that these community members have been engaged, and how are they important in regard to increase in the coverage of immunization. Allow me go briefly with some of them. One is, say, building a trust. For me to trust you is when I'm staying with you. And when I'm staying with you, I give you information, you will pass to your colleague. A meaning friend will convey information to a friend, friend will take a friend. We are the right people to pass information to our communities as we had, and our community members will pass. And then another thing is understanding our community needs. Every community has a unique culture, their social life, and the economic factors. You, as a public health officer or health workers in the room, you need to understand what your community wants and what your community does not need. Having put that in place, meaning our coverage will go high. We are also empowering our communities. How shall we empower our communities? Meaning, if we give them knowledge, they will take the responsibility of their own health. If I've been trained on how things should be done, I'll have the power. I'll take the lead of my community. Otherwise, what will facilitate this is self-sacrifice, conveying the right information to our community members. With this, I beg to stop here. Thank you.
Thank you very much for those parting shots. I now turn to Professor Hassan. The last question, and then you make your parting shots. And the question is, because you already told us what the trend has been when there were not enough vaccines, and now when vaccines got introduced, and you also made serious recommendations alongside Dr. Adut's recommendations about some missing vaccines that are very important for us to consider introducing. On your part, it was mumps vaccine. There were others, but I also remember that Dr. Adut talked about the human HPV vaccine, how that is very important for boys and girls to get it in this country. We have cervical cancer cases that are being seen even in younger, much younger women in this country. So the question is, there is an issue of vaccine hesitancy. The UNICEF colleagues have said, as healthcare professionals, we also contribute to this sometimes. But in your practice, how have you addressed this vaccine hesitancy amongst parents, but also amongst colleagues? You are an educationist, you have taken many of us through the healthcare training, including myself here speaking. How is this being addressed so that we do not happen then to be the ones who derail these vaccination programs? So how do we address this, any hesitance, or how have you addressed it amongst patients and also amongst colleagues? And what strategies have proven most effective in increasing vaccine uptake in your observation over the many years you've worked? And finally, your parting shots. Thank you.
Thank you once again. The issue of vaccine hesitancy. among the parents particularly is obvious. And I could remember one certain neighbor of ours was telling me, that they have a neighbor who refused to get his children vaccinated. What was done was that she was taken to a nearby police station, and she was threatened that if she refused the children to be vaccinated, she will be jailed. So she was forced to accept the vaccination of her children. This measure, of course, was so coercive, and anyone may, of course, frown when hearing this. But it's a big issue of this vaccine hesitancy. It's not only with us here, but I could remember in the campaign of elimination of polio, there are some countries like Nigeria and Afghanistan where the control of religion is very high among the citizens in some areas particularly. They have a very strong propaganda that these vaccines may affect the future of their children, especially in terms of reproduction later on, as it has been mentioned by a colleague here. This is one thing that will make people refuse to go for this. So the key here, key point is that everything that needs to be introduced newly, you need to, first of all, do a survey, and you need to enlist the help of the sociologists with you, social counselors, psychologists. And in itself is a campaign. You need to use the social media to raise the awareness of the importance of this material that's going to be introduced. In fact, the health personnel and the medical personnel may constitute one of the most difficult groups to deal with. If a doctor is sick, he wants to have an opinion in every decision taken by his colleague doctor to manage his illness. And sometimes he may even refuse. So this is something that is very common among us. We really have some low opinion about how things are supposed to be done. In the COVID-19, one of the things that reduce the vaccination level among the community was that the doctors and the health workers were refusing. And then they were listening to what was coming from America, that the vaccine has some terrible side effects. They may lead to cardiovascular accidents. These things, although the percentage was found to be very small, it's 0.00 something, but of course, being a threat to one's life, you may think, that thing is going to happen to me. So that was what people fear. So this group of people need to be given the responsibility to come to the table of advocacy, they themselves. And they by that, may be able to understand the importance of this and recognize, their leadership position in the community, that they have to accept it. But individuals may need special assessment, and this can be done by psychologists and social counselors to do that. But the thing that may make it also a little bit difficult is that a choice is given to a person. The person has the freedom to do that. And of course, the approach should not involve going to legal bodies and sue somebody. In pediatrics, we have probably the obligation of protecting children, and the children are controlled by their parents. They are really recognized to be the #1 line of taking care of children. So ethically, if the parents refuse the vaccination of their children, we will have to talk to them. We talk to them and allay their anxieties. We educate them about the benefits of these vaccines and sincerely tell them about the side effects so that they won't think that something is being hidden from them, and they should know that. In some countries, the protection of the child may fall upon the community if the parents fail to really protect them when looking at the importance of that thing like vaccination. So the thing may go up to the legal bodies because a child cannot consent ethically. He doesn't have the capacity of understanding what's being done for him, despite being useful. In our country here, we still possess our children. We hold them. And maybe I didn't go into our constitution here and see the articles that address this, but I think they should be there. We don't reflect on them and take a good stance when a child is deprived of getting the appropriate and the proper vaccine by the parents. I think people need to protect, this child, so that we really ensure, that his health is prevented from any harm. Thank you.
Thank you very much. We have to be given an opportunity to come to the advocacy table. Others would say, let's not wait for the opportunity. Our profession places upon us a responsibility to be advocates. And so we have to invite ourselves to the table. Like we have invited ourselves in some way here today by South Sudanese Women in Medicine. We are medics ourselves, and we've said, let's come to the table, let's have a conversation, let's begin to influence vaccination programs more robustly in this country. And thank you very much, Prof, for speaking ardently to us and telling us that we have to be on board. You said it in different words, but I believe colleagues here are listening, and we have to ensure that we avert vaccine hesitancy by being the protectors of the children in our community, because our profession confers some level of responsibility on us. So, Apin, your parting shots. You've listened to us. The room is here. There is behavior that has to change amongst us in the community. What do you have to say finally?
I will not say much. I think we need to be engaging frequently. When you look at the population that we are dealing with, 30% of the population is what is meant to be literate in South Sudan. Out of that 30%, 16s are female. So we still need, and our health is in the hands of female. As we all know, they are our life. And if they don't know much about our health, I don't think our health can be okay. So I'm happy for this forum today, and I think as SWIM, we need to engage more with communities in that aspect, especially engaging our females in this country it was quite good with COVID. They were the first to come out to get good coverage. It was 44% always when we started. So I think we need to do more in terms of health of our children. So we need to be engaging, and I think we have started. Forum is there. We have RCC, TWG, led by Mama Mary. So that is a forum that we need to always engage, and I think we need to innovate and see what are the strategies in bringing people like Prof to help us also send some messages across. Thank you.
Thank you very much. Ladies and gentlemen, that has been our panel on clinical perspective on preventable childhood illnesses. I have been your moderator, Dr. Koiti Emily, with these wonderful panelists. We will now have to hand over to you. If you're pleased, you can give us an applause. Thank you. There are enough photos that have been taken, so we can leave.
That has been a very long session. I think we can go for a lunch break now. It's at the 10th floor up. So let's take a 1 hour's break and then we come back. Thank you.